So in today's discussion, we reviewed four main abstracts presented at this last year's ASCO. The first one being an alliance study looking at the combination of enzalutamide with abiraterone versus enzalutamide alone in metastatic castration-resistant prostate cancer. The second being the PEACE-3 study looking at the combination of enzalutamide plus radium-223 versus enzalutamide plus placebo, with a specific focus on what the impact a protocol amendment mandating the use of bone protective agents had on the symptomatic scleral-related event rate, i.e. fracture rate. The third trial that we discussed was the TITAN trial, now focusing on the metastatic castration-sensitive prostate cancer space. This trial looking at the novel androgen receptor antagonist apalutamide versus placebo as a first-line setting in conjunction with standard androgen deprivation therapy. And the fourth abstract we discussed was the ENZAMET trial, one of the plenary presentations at this year's ASCO, similar sort of trial as the TITAN study, looking at enzalutamide, a well-known and established androgen receptor antagonist, plus ADT versus a standard of care, which was defined as including a non-steroidal anti-androgen, so a trial with an active control arm. In terms of the first trial, the Alliance trial, the study was a negative study. So the combination of enzalutamide and abiraterone did not improve overall survival compared to enzalutamide alone. In one of their secondary endpoints, they looked at radiographic progression-free survival. There was a statistically significant modest improvement in RPFS at around 4 months. However, there was greater toxicity and side effects with the combination therapy, and on the balance, given the no OS benefit, basically is not recommended to pursue combination therapy with abiraterone and enzalutamide in the mCRPC space. The second trial, the PEACE-3, combining enzalutamide with radium-223 versus enzalutamide and placebo. So this discussion was focused on the impact of the protocol amendment on mandating the use of bone protective agents. Prior to this, it was not a requirement of the study, despite many national and international clinical practice guidelines stating that patients with metastatic CRPC to bone should be on a bone protective agent such as zoledronic acid or denosumab. That being said, not that many patients were on it at the time of the amendment, just around 40%. And the reason this took place is because a similar trial looking at abiraterone plus radium-223 had the IDMC recommending unblinding of that trial in November of 2017 after noting an increased fracture rate and in fact an increased death rate in the combination of abiraterone plus radium-223. So based on that, the PEACE trial pretty much mandated this change, and what was seen is that pre-mandated protocol amendment, the uptake of bone protective agents was around 40% as mentioned. However, afterwards this increased to around 85%. Prior to that, the fracture rate in the combination arm was just shy of 40%, whereas it was around 15% for the enzalutamide plus placebo arm. Afterwards, at 12-month landmark analyses, the fracture rate after inclusion of bone protective agents effectively dropped to 0. So a pretty profound impact and a clinically meaningful one at that for patients that had to receive bone protective agents on this trial. They basically stipulated that they had to start these drugs and you had to have at least 6 weeks while you were on them before you could get your first infusion of radium-223. Enzalutamide could proceed shortly thereafter with no time constraints. But the study basically just underscored the importance of adhering to well-recognized and well-known guidelines, of which have been around for a number of years now already, and just highlighting how potentially less focus or less diligence when it comes to the utilization of these agents as adjunctive supportive care measures really and truly has a profound impact. And so us collectively as a medical oncology community and clinicians at large really need to strive to ensure that we do include these regimens, barring any kind of standard contraindications in our routine clinical practice moving forward. Thirdly, the TITAN trial. So this was an exciting trial looking at the novel androgen receptor antagonist apalutamide. This drug has been FDA approved for use in non-metastatic or M0 CRPC based on data that came about last year. It works very similar to another drug that, as I mentioned, most are familiar with called enzalutamide, in that it is a direct antagonist to the ligand binding domain of the androgen receptor, blocking translocation translocation of the AR into the nucleus, blocking DNA binding and downstream transcription. So this study basically looked to see whether treatment intensification with apalutamide plus standard androgen deprivation improved overall survival and radiographic progression-free survival as their co-primary endpoints versus ADT plus a placebo. The study was pretty flexible in that it did allow for patients of any kind of background or prognostic profile to be enrolled. The only caveat being they had to have had less than 6 months of ADT total prior to registration. They were allowed to have upfront chemotherapy in the form of docetaxel, given the practice-changing studies of Charted and Stampede. Interestingly, this study only had about 10% of patients receiving upfront chemotherapy, despite just under 2/3 having high-volume disease, the subgroup patient population which was shown and Charted to potentially drive the greatest benefit from docetaxel. That being said, the apalutamide did show a pretty substantial overall survival advantage on interim analysis. The data were immature, and we need to wait for further follow-up before any definitive OS conclusions can be drawn. But basically, at an interim of 24 months, there was an 8% improvement in OS, with the median survivals not reached for both the apalutamide and the placebo arm. Their other co-primary endpoint of rPFS, this was quite substantial and definitive. The apalutamide arm had a decreased rate in radiographic progression or death of around 50%, and this was highly statistically significant. The drug was well tolerated with pretty expected side effects based on the known toxicity profile of the drug and similar AE profile. Despite a higher side effect profile and AEs, quality of life metrics suggest that patients did just as well in terms of quality of life scores, whether they were on apalutamide or placebo. And basically the conclusions drawn by the investigators was that apalutamide potentially represents a new standard of care for pretty much all patients with early new diagnosed metastatic prostate cancer in the hormone-sensitive setting. It should be noted that currently the drug does not have FDA approval for this indication. It is only approved for the M0 CRPC space, and so that is something that will still need to be completed prior to its routine use in clinical practice. The last trial that we spoke about was the ENZAMET trial. This was a large multinational, multi-institutional academic cooperative group trial, primarily spearheaded by the ANZUP group out of Australia. Very similar in design to the TITAN trial, except it used enzalutamide as opposed to apalutamide. It had to be at the time of diagnosis of metastatic prostate cancer in the castrate-sensitive setting. Patients were allowed to be on androgen deprivation for upwards of 3 months prior to enrolling. And basically the difference here being that on the control arm, patients received an active control in the form of a non-steroidal anti-androgen, either bicalutamide, flutamide, nalutamide, etc. This trial's primary endpoint was overall survival, and this was met. It was statistically significant with 3-year overall survival on the enzalutamide arm of 80% versus 72% for those that got the standard of care arm. This trial did allow for concurrent use of docetaxel chemotherapy, and around 50% of patients did in fact get chemotherapy concurrently with either the enzalutamide or the non-steroidal anti-androgen. About half patients as well were high volume as per Charted definition criteria, basically 4 or more bony metastases, of which 1 had to be beyond the axial skeleton and or visceral metastasis. There was greater toxicity in the enzalutamide arm, and specifically those patients that got docetaxel and enzalutamide seemed to have enhanced docetaxel side effects. Namely, they had worse neuropathy, they had worse nail discoloration, and it seemed to sort of potentiate these sorts of side effects. Now, on subgroup analysis, it was found that the 3-year overall survival in those that got docetaxel was 75%, whether they got the standard of care arm or the enzalutamide arm. There was a progression-free survival advantage with a decreased rate of progression or death of around 50% in those that got docetaxel and enzalutamide, but this translated, as mentioned, into a 0 impact in overall survival. And so the investigators concluded, and many in the academic community concluded as well, that At present, concurrent use of docetaxel and enzalutamide would not be recommended given the lack of OS benefit and the enhanced toxicity profile, and the fact that by going through multiple lines of therapy up front, you then sort of do not have access to them later on down the road, and as well any other future clinical trials that may potentially use enzalutamide if, for example, one uses docetaxel up front in terms of therapy. So the main takeaway from specifically those last two trials is that in conjunction with other trials done over the last few years, Charted, Stampede, Latitude, the ARCHES clinical trial as well. Basically, it's quite definitive now that treatment intensification upfront at the time of diagnosis of metastatic castration-sensitive prostate cancer is pretty much universally indicated, barring very select instances where a person may be too frail or have too many comorbidities or other barriers to accessing care. Ultimately, the main sort of conundrum is choosing the best drug or which drug for which patient. Number of different factors can go into this decision-making process, be them patient-specific factors such as mentioned, age, frailty, comorbidity, philosophy of care, how they want to go about treating their disease, certain financial considerations. Docetaxel, obviously, far cheaper and only done with 6 cycles as opposed to enzalutamide, abiraterone, or apalutamide, which is done sort of concurrently, and patients can be on these drugs for years. So it's not inconsequential in terms of both the potential impact on their overall health as well as the financial considerations moving forward. Other things that might impact decision-making include disease-specific factors such as high volume versus low volume in terms of trying to choose between chemotherapy versus an AR-directed therapy, and as well as what your general sense is that the disease is being driven primarily by the AR. For example, in those patients with very high burden of disease but a comparatively low PSA, one might consider using chemotherapy on the suspicion that maybe the androgen receptor isn't the main sort of, or at least the primary driver of that particular disease process. So a lot of nuance that can go into these sorts of questions, and it remains to be seen sort of if biomarkers will help be able to tease out which drug for which patient is going to be best moving forward, and hopefully those will be included in prospective trials set to be used as predictive biomarkers moving forward.